Malignant pleural effusion sometimes can be massive, causing severe dyspnea that needs emergency ICD insertion. Sometimes moderately dyspneic patients can electively be advised for ICD insertion and then pleurodesis. Patient is in supine position or may be in proper position if it is not possible. Under all aseptic precaution, incision is taken in mid-axillary line in 5th intercostal space. Fixation suture is taken right at the beginning to be tied later. Artery forceps dissection is done till intercostal muscle plane is reached. One can place extra holes onto the ICD tubing to ease out the drainage of fluid. Screwing movement while pushing the trocar through the intercostal space, and the other hand helps control insertion of ICD tube for smooth giveaway once ICD enters the pleural space. Ensure the free flow of ICD fluid and then fix the ICD tube in place. Ensure snugly fit sutures for fixation to avoid accidental coming out of ICD. Ensure controlled drainage of pleural fluid about 100 to 150 ml every half an hour, and then doubly clamp the ICD tube to avoid sudden gush of fluid draining out into the ICD bag, as that can cause severe pain and sometimes vasovagal shock due to sudden decompression of thoracic cavity. Remove the clots from the ICD tube under all aseptic precaution and then reconnect the ICD tube to the bag. It helps draining out entire fluid from thoracic cavity and ease out the passage of talc slurry for pleurodesis. Patient should continue doing spirometry exercises and can move around with ICD bag, which is always kept below the level of vest. Once the lung is expanded and the ICD output is less than 200 ml per day, talc slurry is prepared with 4 to 5 grams of medicated talc mixed with 100 ml of normal saline and 10 ml of 2% lignocaine solution. Under strict aseptic precautions, talc slurry is pushed into the thoracic cavity with asepto syringe and then tube is capped. Immediately after this, patient is turned around 360 degrees to avoid precipitation of the talc and then permit the easy distribution across the thoracic cavity. Strong analgesia and antipyretic should be given at this point to mitigate the pain of inflammatory response that is being generated into thoracic cavity. After 1 hour of pleurodesis, ICD fixation suture is cut by assistant while patient is in lateral position. Patient takes deep breath. ICD tube is removed in a stroke and gauze with gel is placed immediately at ICD puncture site and sticking tightly applied over the gauze to avoid air going into the thoracic cavity. About 1 in 1000 patients may experience severe anaphylaxis due to reaction to the talc.